Question 1. A patient presents with a laceration to the palmar aspect of the wrist, resulting in a complete transection of the flexor digitorum superficialis, FDS, to the middle finger and the flexor digitorum profundus, FDP, to the ring finger. Following surgical repair, what is the most appropriate initial splint position to protect the repairs? A. Wrist in 30 degrees extension, MCPs in 70 degrees flexion, IPs in full extension. B. Wrist in 45 degrees flexion, MCPs in 0 degrees extension, IPs in 0 degrees extension. C. Wrist in 20 degrees flexion, MCPs in 50 degrees flexion, IPs in full extension. D. Wrist in 20 degrees extension, MCPs in 50 degrees flexion, IPs in 20 degrees flexion. Answer: D. Wrist in 20 degrees extension, MCPs in 50 degrees flexion, IPs in 20 degrees flexion. This question tests your knowledge of flexor tendon repair splinting protocols, a critical aspect of hand therapy. The keyword initial splint position indicates that immediate post-operative protection is key. The correct position for flexor tendon repair splinting, often referred to as the modified Duran or Kleinert protocol starting position, involves wrist extension and MCP and IP flexion to minimize tension on the repaired tendons, allowing for controlled motion while preventing rupture. Wrist extension shortens the extrinsic flexor tendons, and maintaining some MCP and IP flexion prevents the fingers from going into full extension, which would excessively stretch the repair. For example, a common protective splint might include a dorsal blocking splint, which maintains this safe position. Always remember that proper splinting is crucial for protecting delicate tendon repairs during the initial healing phase. Question 2. A 45-year-old construction worker presents with chronic lateral elbow pain exacerbated by gripping and resisted wrist extension. What is the most likely diagnosis, and what specific muscle origin is primarily involved? A. Medial epicondylitis, flexor carpi ulnaris origin. B. Lateral epicondylitis, extensor carpi radialis brevis origin. C. Radial tunnel syndrome, supinator muscle compression. D. Posterior interosseous nerve syndrome, supinator arcade of Fros. Answer: B. Lateral epicondylitis, extensor carpi radialis brevis origin. This question evaluates your understanding of common elbow pathologies, specifically epicondylitis. The keywords lateral elbow pain, gripping, and resisted wrist extension strongly point to lateral epicondylitis, often called tennis elbow. This condition involves tendinopathy of the common extensor origin, with the extensor carpi radialis brevis, ECRB, being the most commonly affected muscle due to its biomechanical pull during wrist extension and gripping. While radial tunnel syndrome can present with similar pain, the clear exacerbation with resisted wrist extension directly implicates the ECRB tendon. Understanding the primary muscle involved helps guide targeted interventions like eccentric strengthening. Always associate lateral elbow pain with activities involving wrist extension and grip, and you'll likely pinpoint the ECRB. Question 3. A patient sustained a zone V extensor tendon injury to the ring finger. Which of the following is the most appropriate immediate post-operative splint for this injury? A. Static progressive splint with the MCP in 30 degrees flexion. B. Dynamic extension splint with finger cuffs for IP extension. C. Full immobilization with the MCP in 0 to 10 degrees flexion and the wrist in 30 to 45 degrees extension. D. Volar blocking splint with the wrist in 20 degrees flexion. Answer: C. Full immobilization with the MCP in 0 to 10 degrees flexion and the wrist in 30 to 45 degrees extension. This question tests your knowledge of extensor tendon repair protocols, specifically for zone V injuries, which occur over the MCP joints. The keyword immediate postoperative splint signifies the need for protection and proper positioning for healing. For zone V extensor tendon repairs, the common protocol involves immobilization with the wrist in extension, typically 30 to 45 degrees, and the MCP joints in slight flexion, 0 to 10 degrees, to provide optimal slack for the repaired tendon and prevent extensor lag. This position reduces tension on the repair, allowing the tendon ends to approximate and heal without excessive stress. For instance, a common splint is a static volar or dorsal splint maintaining these angles. Remember, positioning the MCPs in slight flexion is crucial for Zone V extensor repairs to prevent overstretching. Question 4. When assessing a patient with suspected ulnar nerve compression at the elbow, what specific sensory distribution should the therapist primarily evaluate? A. Volar aspect of the thumb, index, and middle fingers. B. Dorsal aspect of the thumb and radial half of the ring finger. C. Volar and dorsal aspects of the small finger and ulnar half of the ring finger. D. Volar aspect of the small finger and dorsal aspect of the ulnar half of the hand. Answer: C. Volar and dorsal aspects of the small finger and ulnar half of the ring finger. This question focuses on the anatomical distribution of a specific nerve, which is fundamental for nerve injury diagnosis. The keyword ulnar nerve compression at the elbow guides you to recall its sensory innervation. The ulnar nerve provides sensation to both the palmar and dorsal aspects of the small finger and the ulnar half of the ring finger, as well as the ulnar half of the palm and dorsum of the hand. While options may describe parts of the ulnar nerve's distribution, the key is to recognize that at the elbow, proximal to the wrist, the nerve innervates both the dorsal and volar surfaces of these specific digits. For example, a patient with cubital tunnel syndrome would complain of numbness and tingling in the small finger and ulnar side of the ring finger, affecting both sides of the digit. Always remember to assess both volar and dorsal sensation for a complete picture of ulnar nerve involvement. Question 5. A patient undergoing therapy for a distal radius fracture presents with new onset of severe, burning pain, swelling, skin temperature changes, and significant allodynia that is disproportionate to the original injury. Which of the following conditions is most likely developing? A. Raynaud's phenomenon. B. Deep vein thrombosis. C. Complex regional pain syndrome, CRPS, type 1. D. Ulnar collateral ligament sprain. Answer: C. Complex regional pain syndrome, CRPS, type 1. This question tests your ability to identify the classic signs and symptoms of complex regional pain syndrome, CRPS. The keywords severe, burning pain, swelling, skin temperature changes, allodynia, and disproportionate to the original injury are hallmark indicators of CRPS. CRPS type 1 occurs without a confirmed nerve injury, often following trauma or surgery, and presents with a constellation of sensory, motor, autonomic, and trophic changes. Raynaud's phenomenon is primarily vasospasm, DVT is a blood clot, and UCL sprain is a ligament injury, none of which present with this specific combination of symptoms. Recognizing these disproportionate and multisystemic symptoms is crucial for early diagnosis and intervention in CRPS. Think of CRPS when pain and symptoms seem far more severe than the initial injury would suggest. Question 6. What is the primary purpose of applying a buddy strap or buddy taping to an injured finger? A. To restrict all movement of the injured digit. B. To promote isolated strengthening of the injured digit. C. To provide support and controlled motion for the injured digit by its neighbor. D. To prevent edema in the injured digit. Answer: C. To provide support and controlled motion for the injured digit by its neighbor. This question assesses your understanding of a common, simple hand therapy intervention, buddy taping. The phrase primary purpose directs you to the main goal of this technique. Buddy taping involves securing an injured finger to an adjacent healthy finger, allowing the healthy finger to act as a buddy or splint for the injured one. This provides support, alignment, and controlled passive and active motion, which can aid in healing and prevent stiffness without fully immobilizing the finger. For instance, after a stable PIP joint sprain, buddy taping allows the injured finger to move with the adjacent finger, preventing complete stiffness while healing. Remember that buddy taping is about protected, controlled motion, not complete immobilization or isolated strengthening. Question 7. A 60-year-old patient with osteoarthritis in the carpometacarpal (CMC) joint of the thumb reports pain at the base of the thumb during pinching and gripping activities. Which of the following splints would be most appropriate to reduce symptoms during functional activities? A. Wrist cock-up splint. B. Resting hand splint. C. CMC stabilization splint, example a thumb spica or neoprene sleeve. D. Ulnar gutter splint. Answer: C. CMC stabilization splint, example a thumb spica or neoprene sleeve. This question tests your knowledge of splinting principles for common musculoskeletal conditions, specifically thumb CMC osteoarthritis. The keywords osteoarthritis in the CMC joint, pain at the base of the thumb, and pinching and gripping activities clearly indicate a need for CMC joint support. A CMC stabilization splint, often a custom-molded or prefabricated thumb spica, provides support and limits painful subluxation of the CMC joint, reducing stress during functional tasks. A wrist cock-up or resting hand splint primarily addresses wrist or generalized hand issues, respectively, and an ulnar gutter splint is for ulnar-sided hand/finger injuries. Choosing a splint that specifically supports the CMC joint is crucial for managing symptoms in this condition. Always remember to select a splint that directly addresses the affected joint and its painful movements. Question 8. During a sensory evaluation, a therapist uses Semmes-Weinstein monofilaments. A patient perceives the 4.31 monofilament but not the 3.61 monofilament. How would this sensory status be documented? A. Normal sensation. B. Diminished protective sensation. C. Diminished light touch. D. Loss of protective sensation. Answer: B. Diminished protective sensation. This question assesses your understanding of Semmes-Weinstein monofilament testing and its interpretation, a critical skill in hand therapy. The keyword perceives the 4.31 monofilament but not the 3.61 monofilament is the key to determining the sensory classification. The 3.61 monofilament represents normal light touch, while the 4.31 monofilament represents diminished protective sensation. If a patient can feel the 4.31 but not the 3.61, it means their light touch sensation is compromised, but they still have enough sensation to protect themselves from injury. This is a common finding in conditions like carpal tunnel syndrome. Correctly interpreting monofilament results helps guide prognosis and education, as it indicates a level of risk for undetected injury. Always remember the thresholds: 3.61 is normal, 4.31 is diminished protective, and 5.07 is loss of protective. Question 9. A patient presents with a mallet finger deformity following a basketball injury. What is the recommended duration for continuous splinting of the distal interphalangeal (DIP) joint in full extension for a closed mallet injury? A. 2 to 3 weeks. B. 4 to 6 weeks. C. 6 to 8 weeks. D. 10 to 12 weeks. Answer: C. 6 to 8 weeks. This question evaluates your knowledge of specific treatment protocols for a common finger injury, the mallet finger. The keywords mallet finger deformity and closed mallet injury are important, as treatment durations can vary. For a closed mallet finger, where the extensor tendon insertion at the dip joint is disrupted, continuous splinting of the dip joint in full extension, hyperextension is often avoided, is typically recommended for 6 to 8 weeks to allow the tendon to heal without tension. Removing the splint even briefly can disrupt the healing process. Following this initial period, a gradual weaning schedule is typically initiated. Maintaining strict, continuous extension is paramount for successful healing of this injury. Remember, consistency is key for mallet finger splinting. Question 10. Which of the following is the most appropriate modality for a patient presenting with acute edema following a wrist sprain, demonstrating warmth and redness? A. Paraffin wax bath. B. Fluidotherapy. C. Cold pack application. D. Ultrasound, thermal. Answer: C. Cold pack application. This question tests your understanding of appropriate modality selection based on the stage of inflammation and presenting symptoms. The keywords acute edema, warmth, and redness are crucial indicators of an active inflammatory process. Cold therapy, such as a cold pack, is the most appropriate choice in the acute phase as it helps to vasoconstrict, decrease blood flow, reduce metabolic rate, and ultimately diminish pain, swelling, and inflammation. Paraffin and fluidotherapy are heat modalities that would exacerbate acute inflammation, and thermal ultrasound would also increase tissue temperature. Always remember to use cold for acute inflammation to help manage pain and swelling. Question 11. A therapist is evaluating a patient's pinch strength. Which type of pinch involves the pads of the thumb, index, and middle fingers? A. Lateral pinch. B. Tip pinch. C. Palmar pinch, three-jaw chuck. D. Key pinch. Answer: C. Palmar pinch, three-jaw chuck. This question assesses your knowledge of the different types of pinch grips, which is fundamental for evaluating hand function. The keyword pads of the thumb, index, and middle fingers directly describes the palmar pinch, also commonly referred to as the three-jaw chuck pinch. Lateral pinch involves the thumb pad against the lateral aspect of the index finger, and tip pinch involves the tips of the thumb and index finger. Key pinch is synonymous with lateral pinch. Understanding these specific definitions is critical for accurate assessment and documentation of a patient's functional strength. For example, when picking up a small block with 3 fingers, you are using a palmar pinch. Always remember the specific finger contact points for each pinch pattern. Question 12. A patient with a complete C8 spinal cord injury would likely present with weakness in which of the following muscles, impacting a specific functional grip? A. Deltoid, affecting overhead reaching. B. Biceps, affecting elbow flexion. C. Intrinsic hand muscles, affecting grasp and pinch. D. Quadriceps, affecting ambulation. Answer: C. Intrinsic hand muscles, affecting grasp and pinch. This question tests your knowledge of spinal cord injury levels and their corresponding functional deficits, specifically related to the hand. A complete C8 spinal cord injury typically spares some wrist extension and elbow flexion but significantly impacts the intrinsic hand muscles, which are primarily innervated by C8 and T1 nerve roots. Weakness in these muscles, example interossei, lumbricals, severely affects the ability to form a functional grasp and fine motor pinch. While higher cervical injuries would affect the deltoid and biceps, and lumbar injuries would affect the quadriceps, C8 specifically targets hand intrinsics. Understanding the key muscles innervated at each cervical level is crucial for predicting and addressing functional impairments. Remember, C8 is often associated with the hand's intrinsic muscles. Question 13. Which special test is performed by having the patient place their elbow in full flexion and then externally rotating the shoulder, which may reproduce symptoms of ulnar nerve compression? A. Phelan's test. B. Tinel's sign at the elbow. C. Elbow flexion test. D. Finkelstein's test. Answer: C. Elbow flexion test. This question assesses your knowledge of specific special tests used in hand and upper extremity evaluation. The description elbow in full flexion and then externally rotating the shoulder directly describes the elbow flexion test, which is used to provoke symptoms of ulnar nerve compression at the cubital tunnel. Phelan's test is for carpal tunnel syndrome, median nerve. Tunnel's sign is percussion over a nerve, and Finkelstein's test is for de Quervain's tenosynovitis. Performing this sustained elbow flexion and shoulder external rotation maximally tensions the ulnar nerve at the elbow, often leading to tingling or numbness in the ulnar nerve distribution if compression is present. Knowing these tests helps differentiate between various nerve entrapments. Always associate sustained elbow flexion with testing the ulnar nerve. Question 14. A patient has undergone a Dupuytren's fasciectomy. What is the primary purpose of immediate post-operative extension splinting in this case? A. To prevent recurrence of contracture. B. To promote scar adherence to underlying structures. C. To protect the surgical incision from stress. D. To enhance flexor tendon gliding. Answer: A. To prevent recurrence of contracture. This question tests your understanding of post-operative management for Dupuytren's contracture. The keyword Dupuytren's fasciectomy indicates the surgical removal of diseased fascia, which causes finger flexion contractures. The primary purpose of post-operative extension splinting is to maintain the gains in finger extension achieved during surgery and prevent the excised facial bands from recontracting. While protecting the incision and managing scar are secondary benefits, the overriding goal is to counteract the disease's tendency for contracture. For example, a common post-operative splint would hold the MCP and PIP joints in full extension. Always remember that for Dupuytren's, the main goal of splinting is to fight against the contracture's return. Question 15. When assessing a patient with a suspected scaphoid fracture, which of the following anatomical landmarks would be most tender to palpation? A. Pisiform bone. B. Hook of hamate. C. Anatomical snuff box. D. Lister's tubercle. Answer: C. Anatomical snuff box. This question evaluates your knowledge of specific anatomical landmarks and their clinical significance in diagnosing wrist injuries. The keyword scaphoid fracture is the critical clue. Tenderness in the anatomical snuff box, located on the radial side of the wrist between the extensor pollicis longus and extensor pollicis brevis/abductor pollicis longus tendons, is the hallmark clinical sign of a scaphoid fracture. The scaphoid bone forms the floor of this area. The other options are located elsewhere in the wrist and are not directly associated with scaphoid palpation. Even if X-rays are initially negative, persistent tenderness in the anatomical snuff box necessitates further investigation due to the scaphoid's poor blood supply and risk of non-union. Always remember that tenderness in the anatomical snuff box equals suspicion for a scaphoid fracture. Question 16. A therapist is instructing a patient with rheumatoid arthritis on joint protection principles. Which of the following recommendations is most appropriate for a patient experiencing pain and swelling in the MCP joints during daily tasks? A. Encourage sustained grip activities to strengthen weakened muscles. B. Suggest modifying tasks to use larger joints, example forearm, instead of small finger joints. C. Advise performing all tasks with maximum force to maintain function. D. Recommend avoiding all hand use to prevent further joint damage. Answer: B. Suggest modifying tasks to use larger joints, example forearm, instead of small finger joints. This question tests your understanding of joint protection principles, a cornerstone of managing inflammatory conditions like rheumatoid arthritis. The keywords rheumatoid arthritis and pain and swelling in the MCP joints indicate the need to protect the affected, often inflamed, small joints of the hand. Recommending the use of larger joints for tasks, example carrying a bag on the forearm instead of gripping with fingers, using a palm to push open a door, helps distribute stress and reduce load on the compromised MCP joints. Sustained grip, maximum force, or complete avoidance of hand use are all inappropriate and potentially harmful or functionally limiting. Teaching patients to distribute forces and avoid deforming stress is essential for preserving joint integrity. Think about offloading those vulnerable small joints. Question 17. Which of the following is the most effective initial intervention for reducing severe, acute edema in a post-surgical hand, assuming no contraindications? A. Active range of motion exercises only. B. Elevation, gentle retrograde massage, and compression. C. Application of hot packs. D. Sustained gripping exercises. Answer: B. Elevation, gentle retrograde massage, and compression. This question evaluates your knowledge of acute edema management, a common post-surgical complication. The keywords severe, acute edema, and post-surgical hand indicate the need for immediate and comprehensive management. Elevation helps gravity drain fluid, gentle retrograde massage mobilizes fluid proximally, and compression, example with a compression garment or wrapping, helps prevent fluid reaccumulation and pushes fluid out of the interstitial space. Active range of motion is beneficial but often not sufficient as a sole initial intervention for severe edema. Hot packs would exacerbate swelling, and sustained gripping would increase interstitial fluid and potentially strain healing tissues. Always remember the trifecta for acute edema: elevate, gently massage, and compress. Question 18. A patient presents with a laceration over the dorsum of the wrist involving the extensor digiti minimi tendon. In which anatomical zone is this injury located? A. Zone 3. B. Zone 4. C. Zone V. D. Zone 6. Answer: D. Zone 6. This question assesses your knowledge of extensor tendon anatomical zones, which are crucial for understanding injury patterns and guiding treatment. The keyword dorsum of the wrist and extensor digiti minimi tendon point to zone 6. Extensor tendon zones are numbered from distal to proximal. Zone I is over the dip joint, Zone 3 over the PIP joint, Zone 4 over the proximal phalanx, Zone V over the MCP joint, and Zone 6 is over the dorsum of the hand/wrist. An injury to the extensor tendons on the dorsum of the wrist is definitively within Zone 6. Understanding these zones is vital for accurate diagnosis and for applying appropriate splinting protocols specific to each zone. Visualize the hand dorsum and the zones proximal to distal. Question 19. A patient with carpal tunnel syndrome demonstrates weakened abduction of the thumb. Which muscle is primarily responsible for this movement and is often affected by median nerve compression? A. Adductor pollicis. B. Flexor pollicis brevis, deep head. C. Abductor pollicis brevis. D. Extensor pollicis longus. Answer: C. Abductor pollicis brevis. This question tests your understanding of the muscles innervated by the median nerve and their functional deficits in carpal tunnel syndrome. The keywords carpal tunnel syndrome and weakened abduction of the thumb are key indicators. The abductor pollicis brevis, APB, is one of the thenar muscles innervated by the median nerve, specifically, its recurrent motor branch, and is primarily responsible for thumb abduction, a motion essential for opposition. The adductor pollicis is ulnar nerve innervated, the deep head of the flexor pollicis brevis can be ulnar or median, and the extensor pollicis longus is radial nerve innervated. Weakness and atrophy of the APB are classic signs of moderate to severe carpal tunnel syndrome. When considering carpal tunnel, always think about the median nerve's motor branch and the APB. Question 20. A patient presents with a diagnosis of de Quervain's tenosynovitis. Which two tendons are primarily affected in this condition? A. Extensor pollicis longus and extensor pollicis brevis. B. Abductor pollicis longus and extensor pollicis brevis. C. Flexor pollicis longus and flexor pollicis brevis. D. extensor carpi radialis longus and extensor carpi radialis brevis? Answer: B. Abductor pollicis longus and extensor pollicis brevis. This question assesses your knowledge of specific anatomical structures involved in common tendinopathies. The keyword de Quervain's tenosynovitis immediately points to the first dorsal compartment of the wrist. This condition is an inflammation of the synovial sheath surrounding the abductor pollicis longus, APL, and extensor pollicis brevis, EPB, tendons as they pass through this compartment. These two tendons are responsible for thumb abduction and extension, and activities involving repetitive thumb and wrist deviation can exacerbate the pain. The other options are incorrect pairings for de Quervain's. For example, pain is often felt with activities like lifting a baby or wringing out a cloth. Always remember that APL and EPB are the culprits in de Quervain's. Question 21. Which of the following describes the correct measurement technique for active wrist extension using a goniometer? A. Fulcrum on the ulnar styloid, stationary arm aligned with the lateral midline of the ulna, moving arm aligned with the lateral midline of the fifth metacarpal. B. Fulcrum on the radial styloid, stationary arm aligned with the lateral midline of the radius, moving arm aligned with the lateral midline of the index finger. C. Fulcrum on the triquetrum, stationary arm aligned with the lateral midline of the ulna, moving arm aligned with the lateral midline of the third metacarpal. D. Fulcrum on the dorsal aspect of the wrist over the capitate, stationary arm aligned with the lateral midline of the ulna, moving arm aligned with the lateral midline of the third metacarpal. Answer: D. Fulcrum on the dorsal aspect of the wrist over the capitate, stationary arm aligned with the lateral midline of the ulna, moving arm aligned with the lateral midline of the third metacarpal. This question tests your precision in goniometric measurement, a fundamental skill in hand therapy. The correct technique for active wrist extension places the fulcrum on the dorsal aspect of the wrist over the capitate, the stationary arm aligned with the lateral midline of the ulna, pointing towards the lateral epicondyle, and the moving arm aligned with the lateral midline of the third metacarpal. This alignment ensures accurate measurement of the wrist joint's motion while minimizing extraneous movements. Incorrect alignment can lead to inaccurate readings and skewed progress tracking. Mastering goniometry is critical for objective assessment and clear documentation of range of motion. Always visualize the specific bony landmarks for accurate goniometric measurements. Question 22. A patient with a complete brachial plexus injury at the root level, C5T1, would most likely present with which of the following? A. Intact sensory and motor function distal to the elbow. B. Paralysis of the entire upper extremity, including shoulder, elbow, wrist, and hand. C. Isolated weakness of the biceps and deltoid, with intact hand function. D. Isolated loss of sensation in the small finger, with otherwise normal function. Answer: B. Paralysis of the entire upper extremity, including shoulder, elbow, wrist, and hand. This question assesses your understanding of extensive neurological injury patterns. The keywords complete brachial plexus injury and root level, C5T1, indicate a very proximal and comprehensive injury to the nerve roots forming the brachial plexus. A complete injury at this level results in flaccid paralysis and sensory loss throughout the entire ipsilateral upper extremity, from the shoulder girdle down to the hand, as all peripheral nerves of the arm originate from these roots. Isolated deficits or intact distal function would not be consistent with a complete root-level brachial plexus injury. Understanding the breadth of function that the brachial plexus supplies is vital for comprehending the severity of these injuries. Always think about the entire limb when considering a complete brachial plexus injury. Question 23. What is the primary clinical indicator for initiating therapy with a patient diagnosed with complex regional pain syndrome, CRPS, type 1? A. Patient's pain level is at or below 3/10 on a visual analog scale. B. patient exhibits signs of sympathetic nervous system dysfunction, example temperature changes, sweating. C. All swelling has completely resolved. D. Patient has full passive range of motion. Answer: B. Patient exhibits signs of sympathetic nervous system dysfunction, example temperature changes, sweating. This question tests your understanding of CRPS diagnosis and the criteria for initiating therapy. While pain and swelling are part of CRPS, the primary clinical indicator for CRPS type 1 diagnosis, according to the Budapest criteria, relies heavily on the presence of signs and symptoms related to autonomic dysfunction, such as temperature asymmetry, skin color changes, sweating abnormalities, and edema, that are disproportionate to the inciting event. Therapy should be initiated as soon as CRPS is suspected, regardless of pain levels or resolution of swelling, to prevent progression. Early intervention is crucial, and identifying the autonomic changes helps confirm the diagnosis and guides treatment. Promptly address autonomic changes and disproportionate symptoms when suspecting CRPS. Question 24. A patient reports increased pain and stiffness in the small finger MCP joint, consistent with trigger finger. Which structure is primarily involved in this condition? A. Extensor tendon. B. Collateral ligament. C. A1 pulley. D. Flexor digitorum profundus muscle belly. Answer: C. A1 pulley. This question assesses your knowledge of the anatomical structures involved in common hand conditions. The keywords trigger finger and increased pain and stiffness in the small finger MCP joint point directly to stenosing tenosynovitis of the flexor tendons. Trigger finger occurs due to inflammation and thickening of the flexor tendon sheath at the A1 pulley, which prevents smooth gliding of the flexor tendon during finger flexion and extension, leading to a catching or triggering sensation. The extensor tendon, collateral ligaments, and muscle belly are not the primary culprits. Understanding the role of the A1 pulley is essential for explaining the condition and guiding treatment. Always associate trigger finger with the A1 pulley. Question 25. Which assessment tool is most appropriate for evaluating a patient's self-reported functional limitations and disability related to their upper extremity condition? A. Manual muscle testing, MMT. B. Grip and pinch dynamometry. C. Disabilities of the arm, shoulder and hand, outcome measure. D. Semmes-Weinstein monofilament test. Answer: C. Disabilities of the arm, shoulder and hand, outcome measure. This question tests your knowledge of appropriate outcome measures in hand therapy. The keywords self-reported functional limitations and disability are crucial. The disabilities of the arm, shoulder and hand, outcome measure is a standardized, patient-reported questionnaire widely used to assess the severity of upper extremity symptoms and disability. MMT and dynamometry assess objective strength, while Semmes-Weinstein assesses sensation. The score provides valuable subjective information about how the condition impacts a patient's daily life, which is essential for guiding treatment and measuring overall progress. Always remember that the is designed for self-reported functional status. Question 26. Following a traumatic amputation of the distal phalanx of the ring finger, a patient experiences phantom limb pain. What is the most likely physiological explanation for this phenomenon? A. Persistent inflammation and nerve irritation at the amputation site. B. Reorganization of the somatosensory cortex in the brain. C. Development of neuromas in the remaining nerve endings. D. Psychosomatic response due to the emotional impact of the injury. Answer: B. Reorganization of the somatosensory cortex in the brain. This question delves into the neurophysiological basis of phantom limb pain, a complex phenomenon. While neuromas and local irritation, options A and C, can contribute to residual limb pain, The most likely physiological explanation for true phantom limb pain is the cortical reorganization within the brain's somatosensory cortex following the loss of sensory input from the amputated part. The brain's maps for body parts can remap, leading to perceived sensations from the missing limb. Psychosomatic responses are not the primary physiological explanation. Understanding this cortical plasticity is crucial for managing phantom sensations. Think of the brain's attempt to fill in the gaps after amputation. Question 27. When teaching a patient with carpal tunnel syndrome to use a neutral wrist position during computer work, what is the most important ergonomic principle to emphasize? A. Keeping the keyboard and mouse at shoulder height. B. Maintaining the wrist in slight extension to improve circulation. C. Ensuring the keyboard and mouse are positioned to keep the wrist straight. D. Using a gel wrist rest at all times to cushion the wrist. Answer: C. Ensuring the keyboard and mouse are positioned to keep the wrist straight. This question addresses ergonomic principles for common upper extremity conditions, specifically carpal tunnel syndrome. The keywords neutral wrist position and computer work are key. The primary goal of ergonomic setup for carpal tunnel syndrome is to minimize wrist flexion and extension, which can increase pressure within the carpal tunnel. Positioning the keyboard and mouse to allow the wrist to remain straight and in line with the forearm is crucial. Keeping items at shoulder height is too high, slight extension increases pressure, and a wrist rest used improperly can also increase pressure by compressing the carpal tunnel. Always prioritize maintaining a straight, neutral wrist to reduce pressure on the median nerve. Question 28. Which of the following conditions is characterized by a swan neck deformity and what joints are typically involved? A. Osteoarthritis, dip hyperextension, PIP flexion. B. Rheumatoid arthritis, PIP hyperextension, dip flexion. C. Gout, MCP extension, PIP flexion. D. Psoriatic arthritis, dip flexion, PIP extension. Answer: B. Rheumatoid arthritis, PIP hyperextension, dip flexion. This question tests your knowledge of common hand deformities associated with specific conditions. The keyword swan neck deformity describes a classic hand presentation. This deformity is characterized by hyperextension of the proximal interphalangeal (PIP) joint and compensatory flexion of the distal interphalangeal (DIP) joint, resembling a swan's neck. It is most commonly associated with rheumatoid arthritis due to synovial inflammation and laxity of the PIP joint's volar plate and intrinsic muscle imbalance. The other options describe different conditions or incorrect joint involvement. Recognizing the specific deformity helps in identifying the underlying pathology and planning appropriate interventions. Remember the swan shape with the PIP hyperextended and dip flexed. Question 29. A therapist is reviewing a hand burn patient's wound. The wound is characterized by blistering, a moist, pink base, and is extremely painful to light touch and temperature changes. Based on this description, what depth of burn is most likely present? A. Superficial burn, 1st degree. B. Superficial partial thickness burn, 2nd degree. C. Deep partial thickness burn, 2nd degree. D. Full thickness burn, 3rd degree. Answer: B. Superficial partial thickness burn, 2nd degree. This question assesses your ability to classify burn depths based on clinical presentation, a critical skill in burn care. The keywords blistering, moist, pink base, and extremely painful to light touch and temperature changes are classic signs of a superficial partial thickness burn. A superficial burn, 1st degree, would be red but without blistering. A deep partial thickness burn would be red/white, less moist, and have diminished sensation. A full thickness burn, 3rd degree, would be dry, leathery, and often painless due to nerve destruction. Accurate burn depth assessment is crucial for appropriate wound care and long-term prognosis. Always remember that blistering with moist, painful tissue indicates a superficial partial thickness burn. Question 30. A patient presents with a laceration to the thenar eminence with concern for median nerve involvement. Which of the following tests would best assess motor function of the median nerve in this area? A. Froment's sign. B. Manual muscle testing of the adductor pollicis. C. Manual muscle testing of the abductor pollicis brevis. D. Resisted wrist flexion. Answer: C. Manual muscle testing of the abductor pollicis brevis. This question targets your understanding of specific motor functions of the median nerve in the hand. The keywords laceration to the thenar eminence and median nerve involvement are crucial. The abductor pollicis brevis, APB, is a key muscle of the thenar eminence primarily innervated by the recurrent motor branch of the median nerve, and its weakness is a hallmark of median nerve injury in this region. Froment's sign assesses the ulnar nerve, adductor pollicis. Manual muscle testing of the adductor pollicis directly assesses the ulnar nerve, and resisted wrist flexion assesses extrinsic flexors, which have broader innervation. Testing APB strength, example thumb abduction perpendicular to the palm, provides a direct assessment of the median nerve's motor supply to the thenar musculature. When assessing median nerve motor function at the hand, always focus on the abductor pollicis brevis.